be able to do this program. I'm sorry I can't be there in person. I know I was just there, about 2.5 months ago before all kinds of things started to develop with COVID-19. I'm sure for your program in your hospital, and I don't even think you had testing at that point that I was there. And I think it was around the 10th, 11th or so of March. And I'm sure you could tell me lots of things that you've been through. And I know you've been on the front lines, and I congratulate all of you. So this is an exciting program that we have to go over today, and hopefully you'll find it interesting. And I have a little bit of a surprise that I'm going to start off with. First of all, the content of today's is HIV treatment and prevention. And you've been through these before with me. They're quite educational. There was a pre-test that you may have gotten that you can have a chance to go through. My name is Michael Sension. I work in Fort Lauderdale, Florida. I actually live in Miami Beach, and I'm working from home these days doing telemedicine, telehealth due to the COVID-19 crisis. And I think you all know I had the opportunity to do my training at New York Hospital in Manhattan many years ago, and I have fond memories of New York. I wish I could be there in person, and I look forward to the time when I can come back in person, but I'm glad that we have this opportunity now to go over this educational content. So this is, you are the target audience, and the program objectives are here, and I won't go through them, but there's specifically intended for us to have increased knowledge on HIV risk and HIV risk reduction and prevention efforts. So this is accredited, and people that can use any type of CME credit, this is accredited for that for 1 hour for both nursing, pharmacy, and medical. And the course directors are Rick Ellion and Joe Aaron, and both of these individuals I know personally and are very well respected in the HIV treatment world, and prevention world, both nationally and internationally. And here are the disclosures for the two course directors and myself. And we may talk about off-label and drugs that are in development, which I think is quite interesting. We'll get to in just a minute. So everybody's muted. There is a question and answer messaging box that you can access, and please, type your messages, and we'll also open it up at the end for some discussion. So I'm going to start off actually with a hot off the press, quick review of HIV and COVID-19. I know this is not in the topic here, but I think it's very relevant to what we're all living through and what you're doing right now. And this is content that Raj Gandhi, a professor of medicine at Brigham and Women's in Harvard, just presented yesterday at Grand Rounds at the University of Pennsylvania. And it's content that he developed this week. So it's very current, and I'm glad to share some of it with you. So we're going to first start off talking about three things. Is HIV a risk factor for severe COVID-19? And then, do HIV medications have activity against SARS-CoV-2, the virus responsible for COVID-19? And then, how should we counsel people with HIV regarding COVID-19? So I think it's a real treat to be able to share this information with you. So here is a recent review in the New England Journal, which looks at established and potential risk factors for severe COVID-19. And I think certainly the first five, as Raj pointed out, are things that we accept. They're commonly accepted: older age, chronic lung disease, cardiovascular diabetes, in particular, those two, and obesity. And then what really we're going to try to address is this next category of immunocompromise. And there's a little asterisk by it because, HIV certainly falls within that in terms of our thinking. So is HIV really a risk factor, and what limited data is out there maybe to address this? So We do know that immunosuppression, including advanced HIV disease, is a risk factor for other respiratory infections. And I think certainly influenza is one that we recognize. And however, it's not known if people with HIV are at risk for severe COVID-19. So what do we know about HIV and COVID-19? Well, here is a case series that was recently published in Lancet from Barcelona, Spain. 543 consecutive patients hospitalized with COVID-19. 5 people, so less than 1%, had HIV. And the age range of these patients were 29 to 49, of the HIV positive patients, 29 to 49. Of these 5 HIV positive people, all of them had CD4 cell counts greater than 400, except for one whose T cells count was less than 50 and had concomitant pneumocystis. 4 of the 5 were discharged from the hospital. One was still hospitalized at the time of publication. And it's my understanding that this 5th person has also since been discharged and left the hospital. So all 5 were discharged. And out of all the 543 consecutive hospitalized patients, less than 1% were HIV positive. So here's another study that's actually in press. In fact, it may have been published today in CID. Those of you that may have reviewed CID already, you may have seen this, but I believe it came out either last night or today. And Raj shared these data. He was privy to them. And this is a case series from Milan, Italy. So here we have 47 people with HIV, 28 proven COVID-19, 19 probable COVID-19. So what are the demographics of this population? Over 3/4 male. Almost 2/3 had at least one comorbidity. Most of these patients, 44 out of the 47, were virologically suppressed. And the CD4 cell count average was 636. So 80% of these were on integrase inhibitors, 11% were on a protease inhibitor, and 42% were on tenofovir, and that may be relevant in a few slides, so I'm going to discuss. So of the 47, 45 recovered and 2 died. All right, so the risk of death or admission to an ICU was lower than that among non-HIV positive patients at this same hospital. So the crude mortality overall at the hospital was 17%. Now, the difference in this cohort was that the patients were younger. And again, that may be the confounder here. And it may, we may not be able to really glean too much because it was a younger patient population. How important is that? It's emerging. But certainly 2 out of 47 deaths in the HIV positive patient versus a 17%. So we have less than 5% versus 17% mortality, crude mortality. So here's some data from Germany at the top, and then NYU. And these are both on medRxiv, so they're not even ready for publication yet. But a case series from Germany, 33 people with HIV confirmed COVID-19. Mean age 48, with a range of 26 to 82. And the comorbidities, again, were close to 2/3, 60%. So of the 33, 3 died, 9%. And one of the 3 was aged 82, and another one had a CD4 cell count less than 100. So again, perhaps a lower than expected mortality rate, but of the ones that died, what we would consider to be classic risk factors. And then the NYU experience, again on medRxiv, 21 people with HIV compared to 42 matched non-HIV. So only one of the HIV positive individuals with COVID-19 had CD4 cell count less than 200 and a viral load greater than 50. So they saw similar rates of ICU admission and intubation, mechanical ventilation, and mortality. They did notice people with HIV had higher CRP values. And again, ages tended to be younger. It's a small sample size, as you can see, probably the smallest that we've been looking at, and hard to really glean too much from this, but maybe in aggregate, it's starting to show a pattern. And then Raj is getting ready to publish, and the manuscript has been submitted, the Mass General series. And so their data is here between March and April 26th. They identified 36 people with HIV and confirmed COVID-19, and another 11 possible or probable COVID-19 infections, co-infections. So what were their demographics? Again, 77%, over 3/4, non-Hispanic Black, compared to 40% Black and Hispanic in the demographics of their HIV clinic. So 85% have comorbidities associated with severe disease, and they're listed, as you can see. And this was sort of important, he thought. Almost half lived or worked in a congregate setting. Only 2 of the 33 confirmed and 11 additional possible had CD4 count less than 200, and all except 1 were on antiretroviral therapy. And interestingly, 1 person was diagnosed with new HIV, AIDS, and cryptococcal meningitis at the same time. So I think a reminder to all of you that are on the front lines that as we have this heightened awareness of COVID-19, that one has to remember there are other infections that are out there. So in this particular situation, one can't just stop at potential fever and headache and say it's COVID-19, but actually had concomitant workup showing cryptococcal meningitis. So again, we have twin pandemics, if you will, HIV and COVID-19. So non-HIV comorbidities play a role and are common in people with HIV. And there's a whole CME series we have on HIV and comorbidities. And also they play an important role with COVID-19 outcome. It suggests that, this is important. We need to continue to monitor this. High rates of COVID-19 exist in our racial and ethnic minorities, and that, really calls attention to structural and healthcare disparities that are driving COVID-19, and I think are well recognized with HIV, and a sort of a call to action on why our people of color are so affected again by not only HIV, but we're seeing COVID-19. High rates of COVID-19 among people who live or work in congregate settings, and whether it's nursing homes, apartment buildings, confined office settings. People are vulnerable. And then additional data from registries, again, are urgently needed. So now let's turn our attention to HIV medications have activity against SARS-CoV-2. So kind of a hot topic. So we do know, and it's been reported, that lopinavir ritonavir, or Kaletra, inhibits SARS-CoV protease. So in general, SARS virus protease. So that's been appreciated. And there is ongoing randomized clinical trial of lopinavir ritonavir with interferon beta for MERS infection. It's called the Miracle trial. And Raj actually just called them recently in the last few days just to get an update on this from them. Lopinavir ritonavir has been used as off-label now in people with COVID-19, and there are clinical trials, including one underway by WHO. And you may have reviewed, after I was with you in person on or around March 10th, shortly thereafter, the New England Journal published an article on lopinavir ritonavir and experience in China. And you can see from the graph on the right that there's really no difference between those hospitalized patients that were randomized to either lopinavir ritonavir alone or standard of care. So there really wasn't something there that stuck out, no statistical difference. But there are still ongoing studies, including one by WHO. Now, this was just published this week in Annals of Internal Medicine by the Scandinavian, or actually Austria, excuse me. This came from Austria. And so What they observed was that the EC50 against SARS-CoV-2 was on the order of 16 micrograms per ml. And the EC50, in contrast, for HIV is far less, 0.07 micrograms per ml. So what that's telling us is that obviously the Kaletra exposure one would expect. Now, these are in vitro EC50s. What we don't know is in vivo relative EC50s. But again, the difference between in vitro, the suppression with lopinavir ritonavir for HIV and COVID-2 is substantial. So they have 8 patients that they looked at that received lopinavir ritonavir in a standard dose, 400, 100 twice daily. And they measured the trough levels of 13.6 microgram per ml. So it looks like it's fairly close to the trough level that one needs for COVID-2. For HIV, we usually talk about our trough levels relative to EC50, and we want kind of very high trough to EC50 ratios. But again, this is right on par with that. And the caveat here is that lopinavir is highly protein bound with only about 1 or 2% free drug. So then the estimate of what's actually available and free is much lower. And so, their takeaway from this was that one needs 60 to 100 times higher concentrations required to reach your EC50 at trough levels than for HIV. So that's a heck of a lot of Kaletra that somebody would have to take in order to achieve even target levels. So you can see why theoretically lopinavir ritonavir may have activity, but this may explain why we're not seeing activity in actual clinical practice. Kind of interesting publication from this week in Annals of Internal Medicine. So there's no other evidence that other protease inhibitors like darunavir have SARS-CoV-2 activity. Interestingly, TDF-FTC or Truvada is being evaluated for prophylaxis, but there's no data whatsoever that it has effect on preventing or treating SARS-CoV-2 infection. But the Spanish in particular are taking a look at this. So here are some resources for managing COVID-19 in people with HIV. So in the upper right-hand corner is a reference to the IDSA's treatment and management of COVID-19. Down at the bottom is a link or reference to the NIH treatment guidelines, and then the Liverpool website for COVID-19 drug interactions in particular. And so again, these are COVID-19 monotherapy, but I think they're good resources that Ross shared with us. And then finally, how should we counsel people with HIV regarding COVID-19? And I know this must have come up with you folks in the last couple of months. I certainly have had patients that have said, I have HIV, so I need an excuse not to go to work. And I've had requests along this line and other requests and concerns of people saying, I'm surely going to have a worse outcome. So there are some guidance and guidelines that are out there for HIV and COVID-19. So at the top is AIDS Info, the DHHS interim guidance for COVID-19. There's the IDSA HIV Medical Association that published some guidelines recently in the last few weeks. And then the CDC has information as well. So these three are referenced here. So some practical considerations. If an HIV positive person is not on a protease inhibitor, the regimen should not be changed to include a protease inhibitor. There's no reason to do that. In general, we should be avoiding antiretroviral changes right now unless there's a real compelling clinical reason to do so, especially with so many people doing virtual visits and working from home as healthcare professionals. May not be applicable to you as you're all on the front lines, but certainly those of us dealing with things on an outpatient basis. We want to make sure our patients have 30 days and ideally 3 months of medications and make sure their immunizations are up to date. For people that are undetectable and doing well, we may put off the routine visits. And there's nothing carved in stone that says that they absolutely have to have labs done every 4 or 6 months, and that we can put that off a little bit. So there is a website here and some references from the CDC talking about PrEP during COVID-19. Here's a letter that is referenced here from May 15th. So what can we say about PrEP and CDC recommendations? Well, quarterly HIV testing is recommended, and lab-only visits for HIV and other testings are preferred, so we don't see people in person. So when visits are not available or feasible, CDC recommends home kits for HIV and STI testing. And I can tell you, my organization has ordered many of these that we're getting ready to send out for routine STI and HIV testing at home. These kits can be mailed to the patient's houses, homes. They contain supplies for collecting blood through a finger stick and self-collected swabs and urine, and then they can be mailed back to the lab. And again, self-testing by oral swab is not as sensitive for detecting recent HIV, just a reminder. Again, remember, trying to get people, again, confirmed negative for ongoing medication. And instead of doing 30 days with 2 refills, consider prescribing an actual 90 days of medication. So with that, I'm going to jump into the meat of the actual topic today, and we can come back and address any questions you have with that. But I think I'm happy to share those data because they really were hot off the press, and it was something that Raj came up with just this week, and we're happy to share the content that he developed with you. So now the topic from today, in terms of HIV and prevention, there are several different modules within the actual slide deck. And you can see the topics here: identifying patients at risk, reducing risk, and populations at risk, and diverse populations. But I know you're an advanced audience and you're an academic group, and I think it's a real treat to go right, and I'm going to jump right to the hyperlink of HIV prevention. What's on the horizon? So this really tells you what's in the pipeline, what's being developed. I think you're all familiar with Truvada and Descovy, and I think this takes it one step further. All of this is essentially off-label, but it's an interesting discussion. So what's on the horizon? So let's start off with a case. So could be somebody living right in New York. So who is this patient? Mrs. BD, 45-year-old woman, has one male sex partner, and they have a conventional contemporary relationship, except that once every weekend, every other month, they join 3 other couples at a sex club and exchange partners. So they've tested HIV all the time, and they check for STIs every 3 to 6 months, and they've remained negative. The men have previously agreed to use condoms with any vaginal or anal sex, but recently one couple brought cocaine to share, and condom use was less regular. So Ms. BD and her partner have read about PrEP, but they're reluctant to take daily pills. Right? Real interesting. They're negative, but I think you would agree that there's a lot of risk concerns here. So what would we recommend for both Ms. BD and her male partner, and would the advice be the same for both in terms of how we might advise both of them with regards to PrEP? Should she strictly enforce condom use with male partners, especially during receptive anal intercourse? And I think it's a resounding yes. We should try for that. And then what about daily TDF-FTC, Truvada? What about daily TAF-FTC? And what about just TDF-FTC, using it just before and during the sex club weekends, kind of as an on-demand, or something else, or a combination of the above? And what would you need to make your decisions? Lots of thought-provoking questions here. And again, I'm sorry I'm not there, that we can kind of bounce this around amongst ourselves, but some interesting thinking. Not everything is kind of cookie cutter and by the book in terms of what we do in clinical practice. So here's some data from the hypergay study. So not hypergay, these individuals, but it's called hypergay or hypergay. This is a study done in Paris, and it really looked at a different use of Truvada for PrEP. And this was prior to Descovy being available. But and the question was raised: do people actually need to take it every single day? What if they have sex less frequently and they just want to cover the sexual encounter? So there was a formula: 2 tablets, 2 to 24 hours before sex, 1 tablet 24 hours later, and 1 tablet 48 hours after the first intake. And and this really informed the Paris experience, certainly, and the French experience, and it went on to prompt a very large study to look further. This is the ANRS Prevenir study. So looking at daily versus on-demand PrEP with this formula, much larger. And this study started beginning of May 2017 and it ended just recently, or it's actually going to end very, very soon, the end of May. So again, on demand versus daily PrEP with this formula, you can see the baseline characteristics. So some interim assessment of this showed that HIV infection was very uncommon. In fact, daily PrEP use, it was 0, and on demand, it was 0.2 per 100 patient years. So the global incidence, with a reference standpoint, is 0.09 per 100 patient years. So PrEP was stopped 7 to 10 weeks before infection occurred in both of these cases, that the individuals that caught HIV in this study. Mean follow-up, about 9 months. So the overall estimate of HIV infections averted was 143. There was no difference in adverse events in both treatment arms. And again, the reduction rate was very comparable with on-demand versus daily treatment. And indeed, in Europe, on-demand indication for HIV prevention is approved by the and you can see that down at the very lower left-hand corner of the slide. The on-demand PrEP strategy is not FDA or EMA approved, but is embraced certainly in France as an alternative. So let's look at tenofovir diphosphate and FTC triphosphate levels in the female genital tract and rectum. So this just shows graphically after a single dose, and you look at time point after a single dose, and you look at the relative tenofovir concentration in rectal tissue, which is the dark, let's say, aqua, dark blue, compared to vaginal tissue in red and cervical tissue in light blue. You see that the female genital tract lags behind in terms of tissue levels with at least tenofovir diphosphate and FTC levels in the genital tract. And this has led to, at least with Truvada dosing, suggesting, certainly from the Prevenir study and the hypergay study, that there is some adherence and forgiveness that can occur with Truvada. And we see that maximal dosing we give for both individuals, men and women, and that there's perhaps a little bit more forgiveness with men because we see that the genital tract actually retains tissue levels a little bit higher than the female tract. And so we think that likely it's going to take 7 days daily dosing for women, but perhaps on demand, at least with 4 doses, may be protective for men. And we know from the IPREX studies, for example, that led to the approval of TDF-FTC, that really equivalent exposure of 4 doses or more per week was highly effective at reducing transmission. The people that contracted HIV in the original pivotal study that led to the approval of TDF-FTC or Truvada were people that had drug exposures less than 4 tablets per week. And it was really based upon that understanding that the IPER-Gay and the Prevenir studies were designed and showed very comparable reduction in risk as well. So this just looks at, again, the time to protection with daily dosing of FTC, TDF for PrEP. And now WHO recommends additional HIV prevention measures to be used within the first 7 days. And we generally have this rule of thumb that it takes about 7 days for target levels to be achieved steady state for rectal tissue penetration, and a little bit longer for female genital tract. We see that at least for, if you look at daily doses, it takes a while for maximal protection. In the female genital tract, it takes a little bit longer than in the male genital rectal tissue. These certainly apply to both men and women. What we don't know is more current data with TAF, and there are some, certainly the concentrations in PBMCs are achieved much more rapidly and much more quickly. And again, is that the same thing as protective effect in tissue? Remains to be seen, but certainly TAF PBMC levels are achieved at much higher level, much quicker rates than TDF PBMC levels. So now let's turn our attention to Mr. PF. So who's Mr. PF? He's an 18-year-old MSM, recently begun to accept his sexuality and is exploring sex with multiple partners. Very common in young MSM population. He understands the importance of condom use, but has trouble negotiating their use. He's a high school football player. He's been offered a scholarship to play D1 football at a large university. He doesn't even think about telling his sexual preference to his friends or family. He tests for HIV and STIs every 3 months, and he's been negative. Normal renal function, no other medical problems. He's interested in PrEP, but has concerns whether PrEP could impact physical development at age 18. So what are his options for approved PrEP therapy? And we know that we have both Truvada and Descovy, TDF, FTC. Are they clinically important? Are the differences different? Will cost affect your decision? What if he's paying out of pocket and he can get generic TDF, FTC, let's assume it's out there, much cheaper than TAF, FTC? What about side effects and toxicity? And really it's, that it's the cost decision that's driving this discussion. I'll tell you, that's very real. The city of San Francisco Public Health Department, and Kaiser has weighed in, sort of saying that they just think that the generic cost and the ability to get TDF and FTC outweighs the potential safety, and that most people that are going to be using this are young, and they think it's minimal. But yet, I think we're going to look at some data which would seem to be compelling that TAF seems to give a renal and bone safety improvement. So if we opt to prescribe PrEP, what's the likelihood that he'll stay on his therapy? It's another big question. We know that the drop-off rate, PrEP persistence, if you will, is much lower in our adolescent teen population. So here's some information that was presented at CROI just a couple months ago. And this is public PrEP use in British Columbia. So you look at on the far left. So British Columbia is sort of the ideal scenario for doing studies, where everybody has health insurance. They use a centralized pharmacy. Everybody, and as the presenter of this said, the providers are all altruistic because they don't get paid any money to be a provider in British Columbia. And so it's a great setting to do a study. So here they look at individuals, almost 5,000 that applied for PrEP. And then you look at the number of individuals that qualified for PrEP and the reasons why some may not have qualified. And then you look at those, there was a drop off in terms of those that initiated PrEP. And then there was, again, a drop off in terms of those that were retained on PrEP. So ending up with only about 75% initially of those that actually applied for PrEP. And the reasons are listed. below. And predictors of non-retention, again, were non-MSM risk, young age, no prior PrEP, and inexperienced providers. And you've seen the Discover study, so I'm going to go through this very quickly. This was just a comparator study of essentially Truvada and Descovy, FTAF, FTDF, in an MSM, cis MSM or transgender women population, 99% of people being cisgender MSM population. So no women, no cisgender women in this study. And we know the outcome of this. There was non-inferiority. It led to the approval of this drug. Here are the results. And again, these numbers are not statistically different. It looks pretty impressive. When you do, at first glance, you think that the infection rate was less, but again, the confidence intervals are wide and overlapping for both TAF. And this led to the approval of FTAF, and we certainly would say that FTAF or Descovy was as good as Truvada in preventing infections. There were some differences, however, in terms of bone safety. So what we see is the reduction in bone mineral density over 48 and 96 weeks in blue with FTDF compared to FTAF, where there seemed to be an increase in bone mineral density, both at hip and spine, whereas a decrease in TDF. And this looks at both less than and greater than 25 years of age. Why might that be important? And that's because normal bone physiology, if you will, is such that in our younger people, bone deposition and bone growth is occurring up until about age 30. So here's an 18-year-old who's concerned about his health, and again, we have some evidence that TDF, but not TAF, can impact bone growth, which would be normal and expected in a younger population. And I think this is relevant. Personally, I am, I'd be interested to hear what your thoughts are, but it certainly influences the decisions and the medication that I'm using for PrEP, and it mirrors my decision making on what I've been doing for treating HIV as well, and these types of data. So now let's turn our attention to RD. Who's Ms. RD? She's a 24-year-old woman who has sex with men. She knows that she has at least one HIV-positive male partner who occasionally insists that she have sex without a condom. She also has other male partners exchanging sex for money or housing. She's had syphilis, but has been HIV negative, most recently on a fourth-generation asset. So she's fortunate, but at high risk. She's asymptomatic, and she just can't take pills. She uses a birth control implant that was implanted 6 months ago. So I'm just not going to take pills. What do we have for her, and what might be on the horizon? What choices are available in the near future? So, you may have heard of cabotegravir and a vaginal ring that's been studied in Africa, the dapivirine ring. So let's look at this. Dapivirine. There are some dapivirine rings studies that have been looked at, and what is this? It's a small little ring. I say small, but if you actually see it, it's not quite so small. And the woman has to insert it into the vagina up into around the cervix, and then they randomized women to receive the ring and to versus those who did not, and overall the results were fairly unimpressive. However, when they looked at when they took the ring out and they analyzed it, they obviously, if the woman had the ring in and it was in for an entire month prior to putting in another ring, and so there was interval insertions of the ring. If the ring was in the vagina the entire time, when they section the ring and analyze the drug levels in the ring, they should have no drug levels. And so they were able to ascertain the actual adherence for the dapivirine ring. And why might this be important? Again, it was a study that was largely done in Africa. There is a nominal incentive when people come for their visits, and and it's normal for participants in clinical studies to want to please the investigators of the study. So what was observed was that not infrequently women weren't putting the ring in, and they would put it in just right before going to the appointment, so it looked like it was in. But then when they would analyze the depivirine ring, it was full of drug, and it should have been all depleted in the interval time period for before getting another ring. So what they found was that in terms of adherence, if women actually used the ring like it should have been used, that there was actually substantial risk reduction. And so the top third of adherence was equated with actual, close to 100% risk reduction, and then the middle third and bottom third. And the reason why I'm presenting this is that this is estimated. We really anticipate that the depivirine ring is going to be approved, and it may very well already be approved, as far as I know, but any week now, any month now, for use in Africa, and we might be seeing this as an opportunity even in the United States in the future. What about injections and cabotegravir, which I think we've heard about the cabotegravir data in HIV positive people for maintenance therapy from the Atlas and FLAIR studies. But there's actually ongoing studies, both the HPTN 083 and HPTN 084 are studies looking at cabotegravir as an injection for PrEP. And right now, these studies are ongoing. They haven't been reported on yet, but HPTN 083 is a study in MSM and transgender women. And, the design is as you see it. It's comparing cabotegravir as an injection versus TDF-FTC or Truvada daily. And so it's placebo controlled. So people get an injection and take a pill, and it's divided into groups of where either the placebo, the injection is placebo, or the injection is cabotegravir, and then likewise with the Truvada. 084 is cabotegravir for PrEP in HIV uninfected women, again, versus Truvada. And the study design is very similar, except that the patient population, and here's the study design, exactly the same as 083, but the patient population is high-risk women in Africa. And again, a very large study, and we should get some information on cabotegravir for prevention coming up. All right, so now let's talk about TS, a Latino man who has sex with other men. He tests frequently for HIV, and he's been negative. He's in a relationship now with an older man who's physically and emotionally dominating. His partner will not disclose his HIV status, insists on having sex without a condom, and Mr. TS only has receptive anal sex and was recently diagnosed with rectal gonorrhea. He takes Truvada, TDF-FTC, but his partner has thrown away his medicine twice. He tries to accompany him with healthcare visits and really wants to be in the room with him. So the young man's been able to hide his TDF-FTC and leave the house by making up other reasons. He asks you, when will there be a truly long-acting therapy? I mean, he's just really concerned about daily therapy. So this brings up a few things. We're going to talk about what's on the horizon for long-acting, but it also brings up intimate partner violence in HIV that we need to be aware of. And not just we think about domestic violence in perhaps more often in terms of women being more vulnerable, and certainly that's very real, but we also know that it's not limited to women and heterosexual couples. And same-sex couples can be victims of intimate partner violence, and that can lead to increased HIV risk, forced intercourse, physical trauma, and somebody who's unable to negotiate safe sex because perhaps their financial situation, they're in an otherwise situation where they feel they have no options. And the abuser may also be at elevated risk as well. So what we see is this kind of balance between partner resistance, frequent visits, stigma, cost, and then the need for autonomous use of PrEP. and being able to negotiate sex, having the ability to protect yourself and not depend upon a partner to protect you from them. So how do we talk to him about his relationship? What resources are available for men who are victims of intimate partner violence, IPV? And what can we tell Mr. PZ about options for long-acting preparation? So let's talk about that. So there now is really a look at long-acting subcutaneous antiretroviral therapies as implants, and one in particular is islatravir is being looked at in a preparation you see in this photo, about the size of a matchstick that can be inserted under the skin. We're going to talk about this in a minute. And it dissolves over time, over about a year's time period, and gives therapeutic levels of drug over potentially an entire year or even more. We know there are highly potent antiretroviral agents that are out there in development with very long half-lives. And they can be administered not only as an implant, but subcutaneously. And then we'll also talk about, in addition to islatravir, the capsid inhibitor being developed by Gilead, GS6207. So let's talk about that. The Gilead now is in development, and it's moving right along very quickly. A capsid inhibitor. It's first in class. So what is capsid inhibition? So capsid is important for two reasons. That inhibition of the capsid occurs at two locations within the viral life cycle. So, for example, the capsid has to disassemble on HIV infection of the cell. So that can be blocked on the left side. But then the capsid also has to assemble again during virus assembly or virus production. And you see that occurring on the right side, capsid assembly. So a capsid inhibitor actually blocks at both steps in the viral life cycle. So we see the step on the left and the step on the right, and it modulates these processes. So here is some data that's recently been presented showing us the very high levels that can be achieved with capsid dosing. And this is a single dose that was given, and you look at then the drug levels of 4 different doses and follow it out over time. And if you just look at the 12-week time period, 3 of the 4 doses are well above the EC95 for virus, and that's very compelling. Here is a dose response curve of subcutaneous injection, where individuals, it shows the actual activity against HIV virus. So you see a single injection was given, and one sees the viral decay or viral decline over 10 days. And this was monotherapy lead-in prior to individuals starting BF-TAF or Biktarvy. So we know that the drug has a potent HIV activity, and it has a very long half-life, and certainly is being thought of not only for HIV treatment in a sort of a long-acting preparation, but is possible and is certainly going to be thought of in terms of HIV prevention, in terms of long-acting. There is an oral formulation of the capsid inhibitor, and these are data that was presented at CROI 2 months ago, looking at different doses of an oral formulation, and again, how it achieves very high, good levels that can be seen post-dose after 35 days. So now I'll turn our attention to islatravir, being developed by Merck. Now that was the preparation, the nucleoside reverse transcriptase translocation inhibitor, and it has multiple mechanisms of action that are depicted here. And this is a long-acting preparation that, as you saw previously, is being looked at for very long-acting and in an implantable device that dissolves over time. It also can be given as a single oral monotherapy. and it has a half-life of 80 to 130 hours as an oral preparation. And
Dr. Sension,
look at,
I'd hate to interrupt. I think we have a hard stop at 1:15. So
okay,
if we
I
could,
will.
if anyone has any questions right now, if you want to just address those, or
Sure. I'm going to wrap things up in 60 seconds. So here we have islatravir, and it's been shown to prevent in rhesus macaques, and it's being looked at for prevention. And broadly neutralizing antibodies are also being looked at for prevention. And there's ongoing clinical trials looking at broadly neutralizing antibodies in Africa for prevention. So, and then finally, the vaccines that have been looked at have not been quite so exciting. And at CROI 2 months ago, the large vaccine study 702 was presented showing that there really was very little hope for a vaccine, at least on the near future for HIV. So yes, thanks for that information on the hard stop, CJ. And we'll, if you want to open up maybe it's easier to ask questions orally, or
yeah,
you can
I'll
display
just
the.
take them off mute. And so if anyone has any questions, feel free.
I think they're good. We don't have any questions at the moment.
No.
Yeah, they're good.
Thank you.
Okay, well, thank you very much, and I'm glad to be able to share some of these data. And I think Jennifer has the complete slide deck, at least from the prevention aspect.
Yes.
And you,
I'll share it with the team.
very good.
Thank you,
Thank you
Dr.
so
Sension. Thank you, Jennifer. I'll be in
Thank you.
touch.
No worries. Thank you so much. Be safe, guys.
All right, bye-bye.
God bless.
Bye-bye.
God bless as well. All right, I'll send you guys all the slides. Do not leave.
You still there?
I'm here.
Yeah. Great job, as always.
Yeah, I just, it was hard for me to know what the stop time was, CJ, and I apologize for that. I
No.
probably should have.
No, she literally just told me that they needed a hard stop at 1:15. So,
Okay.
so I tried to message it, but no, that's why I'm sorry to interrupt. I don't like interrupting you.
No, I'm glad you did, but because I didn't see the message. But yeah, it's unfortunate that we got a 15-minute delay in starting, because that it really went about 45 minutes, or about yeah, it went about an hour, and if we could start on time, I could wrap those things up earlier.
Yeah. So, all right. Well, enjoy the rest of your day. I'm gonna head down to the beach now after I send them.
Enjoy the beach, and enjoy the weekend, and have a safe trip back.
I will. I'll be in touch with you soon. Okay.
All right, sounds good.
All right. See you later.
Bye.
Bye.